This presentation is about iron deficiency in the female athlete. So what is iron deficiency? There are 3 stages. The first stage is storage iron depletion. This is where iron stores are depleted, but there is still adequate iron supply in circulation. This will show up as low ferritin levels in blood work. The next stage is early functional iron deficiency. This is where red blood cell formation is impaired, but no severe anemia is detectable. The third stage and the most severe is iron deficiency anemia. This is where there is insufficient iron for red blood cell formation, which leads to smaller and lighter red blood cells. All lab values will be abnormal. Here are some signs and symptoms of low iron. Things like fatigue, increased heart rate, palpitations, impaired exercise tolerance, increased lactic acid production, decreased ability to maintain normal body temperature, glossitis, angular stomatitis, spoon-shaped nails, atrophy of taste buds, and pica. The populations at risk of iron deficiency: 6-month-olds to 4-year-olds due to increased requirements with growth rate, adolescents, specifically females, due to menstruation, pregnant women, individuals with celiac disease due to malabsorption issues, vegetarians due to absorption issues of non-heme iron, individuals who intensely exercise, and individuals with hypochlorhydria. Heme iron versus non-heme iron. Heme iron comes from animals, and it's present with hemoglobin or myoglobin molecules and released by proteolytic enzymes in the lumen. Heme iron does not require binding proteins, and uptake can be as efficient as 40%. Non-heme iron is bound to other foods, usually in the ferric form. In order for it to be used by the body, it must be reduced to ferrous iron by brush border enzymes or dietary agents. Absorption depends on levels of inhibitors and enhancers, and the availability is between 2 and 20%. Here are the RDA for certain populations and some food sources. So some heme sources of iron include oysters, beef liver, sardines, beef and chicken, and some non-heme sources include things like white beans, lentils, spinach, tofu, kidney beans, and chickpeas. Iron metabolism. The regulation of iron balance is dependent on iron status of the individual and the iron obtained from the diet. Individuals with high iron stores will absorb less than individuals with low iron stores. Promoters of iron include things like vitamin C and certain organic acids, and iron inhibitors include things like phytates, phenolic compounds, and calcium. There is an inverse relationship between iron absorption and ferritin, which suggests absorption decreases to cover iron losses to prevent storage. Female athletes and iron deficiency. Female athletes are at a greater risk for developing iron deficiency due to insufficient dietary intake, menstruation, increased iron losses via sweating and hemolysis, GI bleeding, and acute inflammation due to exercise. There is no additional RDA for female athletes. However, research suggests iron requirements for endurance athletes should be increased by 70%. A study found low iron intake and low ferritin levels in female marathon trainers. And studies suggest intake for other nutrients were adequate except for iron. Female vegetarian athletes have been found to have significantly lower serum ferritin levels compared to meat-eating athletes. Studies indicate female athletes who participate in mixed anaerobic and aerobic sports, things like volleyball, handball, swimming, track and field, had the highest risk of iron deficiency compared to athletes just performing aerobic sports or just performing anaerobic sports. Iron deficiency in athletes negatively impacts strength and skeletal recovery, as well as aerobic capacity and muscle fatigue. Elite female volleyball players were split into 2 groups. There was an iron treatment group who received 325 milligrams of ferrous sulfate and a control group. The iron treatment group received supplementation for only 11 weeks of their 29-week season. Iron status was measured 10 weeks after cessation and 18 weeks after cessation of iron supplementation. And the results showed that the benefits of iron supplementation completely disappeared at 10-week cessation of supplementation. and this illustrates that supplementation for only part of a training period is not sufficient. So this was a study in female long-distance runners, which found that elevated hepcidin levels were observed during intense training periods in long-distance female athletes, despite adequate consumption of iron. Hepcidin is a mediator of iron homeostasis, and expression is upregulated by increased iron stores and inflammation. Pro-inflammatory cytokines such as interleukin-6 stimulate hepcidin production, resulting in iron deficiency. Increased presence of interleukin-6 is observed with increased exercise. This was a study investigating the relationship between iron and vitamin D status in elite female athletes. It was conducted with 219 females, ages 14 to 34, and vitamin D deficiency was defined as 25-hydroxy-D less than 75 nanomoles per liter, which equates to about less than 21.6 nanograms per milliliter. Iron deficiency was based on ferritin, soluble transferrin receptor, total iron binding capacity, and blood morphology indices. The results illustrate that the percentage of vitamin D deficiency subjects was 75% higher in the iron deficiency group than in the normal iron status group. The mechanism is not entirely known, but is thought that iron deficiency disturbs vitamin D3 synthesis because the conversion of cholecalciferol to calcitriol requires two steps of hydroxylation, which depends on enzymes containing heme. And in the reverse, vitamin D deficiency may impair iron availability and absorption due to increases in cytokines, which increase hepcidin concentration, again, which is often seen after intense workouts. So this was a study conducted on female athletes and heavy menstrual bleeding, or HMB. And it was the first study to identify HMB as being a common problem among female athletes. It found that 35.5% of marathon runners met HMB criteria. And due to increased blood loss, these individuals were more likely to have iron deficiency and iron deficiency anemia. Previous research showed us that 2/3 of individuals with HMB have iron deficiency anemia. And this study indicates that it's necessary to bring more awareness to this issue, and supplementation may be required. Just to wrap things up, iron deficiency and iron deficiency anemia are prevalent among female athletes. More awareness must be brought to this issue, and supplementation is often warranted along with high iron intake in the diet. Female athletes need to be educated on the difference between heme and non-heme iron and ways to enhance absorption and things that will inhibit absorption as well. And then emerging research illustrating that deficiency in iron is linked to deficiency in vitamin D is something that we should all be aware of. This page is my references. Thank you so much for listening to this presentation.